Hello and welcome friends. Today let's discuss a case from the endocrine system, a patient who has come to you with excess of urine output known as polyuria complaint. Now we have a history attached to this topic that a 33-year-old lady complains of excess of water intake or polydipsia. Her symptoms soon started after a road traffic accident which happened 6 months ago. Her daily urine output is around 3.5 liters and her lab investigation shows that her urine osmolarity is low and her basal ABP or the antidiuretic hormone level is also low. While on the imaging of the brain, the MRI of the gland pituitary, it shows a bright spot. Which of the following is the most likely cause for her condition? The options that we have with us are: is it a case of central diabetes insipidus? Is it a case of nephrogenic diabetes insipidus? Or is it a case of primary polydipsia? Or the most scary option that you might find in most of the exams? Yes, none of the above. Whenever I was as a student used to see this option, none of the above, I used to think that the examiner wants to fool me so that I go and mark that one. Okay, so it might become a Babaji ka Thudu for you in the exam. Or the examiner is very clever. While telling me as an option none of the above, he wants to call me at the Haveli. So let's not go to the Haveli today. Let's go to the posterior pituitary. Chalo, posterior pituitary mein. Now, there is a patient who has come to us with excess of urine output known as polyuria complaint. Remember, the definition is the most important thing here. If a person produces more than 3 liters of urine in a day, or as per the body weight, the urine output is more than 40 ml per kg per day, that quantifies the patient for polyuria. I remember this question came in NEET recently, that is it more than 50 or 40? We have cross-checked it from many sources, we keep it at above 40. Now I have a patient with polyuria. I want to ascertain the urine osmolarity in the patient. And if at all the urine osmolarity in the patient is more than 300, that it's within the normal range, what do I think about? I think about a solute which is dragging the water along the course by the process of osmosis. Like glucose and mannitol. If you know, renal glycosuria happens when the RBS is above 180. Now these glucose molecules will shed themselves into the Bowman's capsule in the glomerular filtrate. And with the flow of urine, they will travel all across the nephron, reaching the last part collecting duct. But on the way, they have a capacity to drag the water along the course by the process of osmosis. Same goes with the wonder drug mannitol, which is often used for treating patients of raised ICT. If you remember, it's an osmotic diuretic. While on the other spectrum, if the patient has got a low urine osmolarity, that is above 300, we think of two conditions. One is diabetes insipidus due to deficiency or resistance to the hormone ADH. Or maybe the person due to some reason is drinking excess of water, primary polydipsia, right? So let's try to find them. Why are they producing so much of urine, polyuria, in patients with DI or primary polydipsia? Let's try to find them. From where do they get so much of urine? You don't produce so much of urine, okay? Now, I have a patient with polyuria whose urine osmolarity is low. That means the urine is passed out dilute. I can have two ways to assess this patient. Either I can get the serum ADH levels done in the patient, or maybe I can do a test which is known as a water deprivation test. As the name suggests, the patient I will deprive of water. I will tell the patient not to drink water for next 2 hours, 4 hours or 6 hours. And that will induce what? Dehydration. Think about it. If you don't get water, the first thing which happens is that you start feeling thirsty. No, that's the second thing. The first thing will always happen is there is release of ADH which is coming and reabsorbing water from me. Correct? Now, second thing which will happen is the thirst center getting stimulated. Now I stop the patient from drinking water in spite of being thirsty by this water deprivation test. Depriving the patient of water will induce dehydration, will increase the serum osmolarity, will induce the ADH production and action. And finally, patient will reabsorb water in the renal tubules. Now I check up on the urine osmolarity in such cases. After doing the water deprivation test, urine osmolarity is unchanged or it improves. That means few hours back a patient who was producing dilute urine is now passing out concentrated urine. That means the ADH formation and action is perfect. That signifies a case of primary polydipsia. That means the patient was just drinking a lot of water, producing large amount of dilute urine. If the urine osmolarity remains unchanged, then I think about deficiency or resistance to ADH, that is diabetes insipidus. In this case, we'll go and do a test known as ADH stimulation test. I'll give my patient a molecule ADH through a pharmacological route, and then I check upon the urine osmolarity in the case. If the urine osmolarity improves, it means that the patient was having deficiency of ADH. Now he got the ADH, the action is perfect. If the patient is suffering with deficiency of ADH, you know this is known as central diabetes insipidus. Or maybe if the urine osmolarity is unchanged, then we think about what? That the ADH is unable to act on the renal tubule. That's a case of nephrogenic diabetes insipidus, right? Now, before the other side, if the patient's serum ADH is low, less than 1, or if it's more than 1. If it is more than 1, that means the serum ADH of the patient is high. I think the patient's ADH molecule is unable to act on the renal tubule. It's a case of nephrogenic diabetes insipidus. While on the other spectrum, if the serum ADH is low, I can think about two things. Either it's a case of diabetes insipidus, central, or maybe a patient of excess of water intake, primary polydipsia. Just imagine this. If you don't drink water, your serum osmolarity goes up, and then the ADH will come out to reabsorb water. If you drink more water, your serum osmolarity will go down. Will that amount of ADH come or no? No. So maybe there is some decline in the serum osmolarity in people who are overhydrated by drinking a lot of water. That will actually increase the threshold for the release of ADH, right? So now we do an MRI of the gland pituitary. So what are we going to see? We are going to localize on the posterior pituitary and we are going to see something bright over there. Remember, bright spot. Bright spot is good for the patient. If the bright spot is there, yes, it basically means that the patient's posterior pituitary is working. But if the posterior pituitary is not working, we don't see a bright spot. That means it's a case of what? Central diabetes insipidus, lacking ADH hormone or deficiency of ADH. If the bright spot is present in the case, then it means that the posterior pituitary is functioning. Just now, due to some reason, the threshold for the ADH release has gone up. That is a case of primary polydipsia, right? So as they say, doctor may not be the bright, the patient has to be bright in the sense of bright spot. Many of the doctors face this problem. They are not considered bright by their patients because they've got a good handwriting. Okay. Now, primary polydipsia means excess of water intake. But why does it occur? It occurs due to a factor which is known as dipsogenic. As I was trying to tell you this, you know what will happen? If I am going into dehydration, the thirst center will come and get stimulated, correct? Now this time the thirst center gets stimulated at a lesser amount of dehydration. That means that there is decrease in the osmoregulatory center. So my thirst center gets stimulated quite early. It can occur in certain conditions like granuloma, sarcoidosis, infection, TB, and don't forget TB is our national disease anytime. Head trauma, demyelination like multiple sclerosis, drugs, antihistaminic, antidepressant, and diuretics. Remember this, antidepressant, antihistaminic cause a lot of dryness of mouth. You must have taken an antihistaminic anytime. You must have experienced this. You keep on drinking a lot of water. That is dipsogenic factor. And of course, idiopathic. The doctor is idiot and the patient is pathetic in this case. Second is psychogenic. The person is under stress. To relieve the stress, they keep on drinking a lot of water. That is psychogenic polydipsia. Or maybe iatrogenic, like someone has told the patient to drink a lot of water. Now in this COVID time this is happening. From the WhatsApp university I've seen many people have become doctors. And they keep on advising everyone to drink a lot of water. That will basically induce diuresis and all the toxins from the body will come out. Okay. So maybe a patient who is on antidepressant is always crying, "Mujhe drug do, mujhe drug do." But if it is causing a dipsogenic kind of a polydipsia, maybe after a few weeks and months, he will ask for this. "Mujhe jag do, mujhe jag do, mujhe pyas lag rahi hai, mujhe jag do." So he's all the time happy to drink a lot and lot of water. Okay, primary polydipsia. Oh, it's a lot of water he had it. Now, a case of central DI. What are the causes for this? Causes of central DI is Binod. You remember Binod? He must be friends of the three idiots. Yes. The B of the Binod stands for the birth problem. Can be a genetic problem. Remember, central DI is more commonly autosomal dominant than recessive. And don't forget the autosomal recessive, Wolfram syndrome, the DID-MOD, diabetes insipidus, diabetes mellitus, optic atrophy, OA, and the last D, deafness. I stands again for the idiopathic. Binod is an idiot. Infection, another I of the three idiots is infection, meningitis, encephalitis. Inflammation like Wegener's and lupus. N stands for neoplasm like the primary CNS tumors or maybe secondaries in the brain. O stands for the toxins here, snake venom and tetrodotoxin. And D stands for the damage, head injury or surgery. So Binod. Next time you see this thing Binod somewhere on the social media, think about the causes of central DI. And I'm very sure every college that we study in has got a Binod. Who is this Binod in the college? Yes. Who keeps on talking, keeps on entertaining people, and he doesn't have any sense in his mind. Okay, what he is talking about. Now, what are the causes of nephrogenic diabetes insipidus? Where we have the ADH resistance coming in. The simple mnemonic is not go corona go, it's go COVID go. The G stands for the genetic cause, yes. The C stands for the carcinoma, can be a sarcoma. And most important, C stands for calcium. Remember, hypercalcemic patients are having a lot of diuresis. They have nephrogenic DI with them as a problem. Because of that, they have polyuria as a complaint. O stands for obstruction, that is ureteric. V stands for vascular, sickle cell disease, ischemia like acute tubular necrosis. The I stands for infiltrative amyloidosis. And D stands for drugs. And O stands for the granuloma, that is sarcoidosis. But this has been a question. What are the causes or the iatrogenic or the drug-induced causes of nephrogenic diabetes insipidus? Don't worry, I've got a mnemonic for this also. A, B, C, D for my life. A stands for aminoglycoside. B stands for the amphotericin B. C stands for cisplatin. D stands for demicocycline. F stands for foscarnet. R stands for the rifampicin. MY stands for methoxyflurane. And life, don't forget lithium. Yes. You might be wondering why I'm telling all this story, because these are very common one-liners that you get in the exam. So maybe the mnemonics are the best route to remember all these one-liners. So why did this go COVID go came? Because we had this great sentence as go corona go. Okay, still not gone. Let's shout it again. Now we go back to the question. 33-year-old lady complains of polydipsia. Symptoms soon started after a road traffic accident 6 months ago. Her urine output is 3.5. She is polyuric. She has got a low urine osmolarity and her AVP level is also low. MRI shows a bright spot. Which of the following is a cause for her condition? Central DI, nephrogenic DI, primary polydipsia, or none of the above? To understand this, let's quickly revise everything. In patients of CDI or central diabetes insipidus, AVP levels are low, bright spot is absent. In patients of nephrogenic DI, AVP levels are high, bright spot is present. In patients of primary polydipsia, AVP level is low, but the bright spot is often present. So what's your correct answer? Primary polydipsia. But the point here is, why did it happen? Did it happen because of the road traffic accident causing head injury as a cause of primary polydipsia or something else? Let's find. कुछ तो गड़बड़ है. Just imagine a person meets with a road traffic accident. That's not a very pleasant event. Later on, the patient thinks about that whole episode and gets a lot of stress because of the trauma, and it is known as what? Post-traumatic stress disorder. Maybe to relieve the stress, the person keeps on drinking a lot of water. So this is a classical story of psychogenic polydipsia, right? So don't take too much of stress in this COVID times. Don't be a Binod, please. Be a Sonu. Maybe a Sonu Sood who makes people all around the country so happy. Or maybe another Sonu from Zomato. Sab badhiya hai. Who is happy in every kind of a situation. Or maybe a health worker at home who comes from duty, is also happy at home. He utilizes all the things in the hospital at home nowadays, like this, using a face mask to filter the tea. Great ideas. This is what our Prime Minister says. Aapda ko avsar mein badal diya. Okay, let's convert this aapda of pandemic into an avsar to learn new things in a better way. So guys, please do attend the DAMS DVT session this year. And we'll try to revise endocrine in a quite different way. All the best. Thank you very much.